So with that, we'll move to Minoryx, and we have Arun Mistry, who's the CMO at Minoryx, who's going to come talk to us.
Good afternoon, everyone, and thank you very much to ALD Connect for inviting us again to present our update on the liraglutide program, and also to talk a little bit more about the Calyx study, which is the ongoing phase 3 study in the US and globally. So I'm Aaron Mistry. I'm a physician by training, just like Vinod was before as well and is. My background is pediatrics and clinical practice, 10 years of practice before jumping into the industry and working in development and medical affairs for a long time now. So I think you've been hearing about Minoryx and liraglutide for some time, but I know there's many new faces in the audience today and probably online. Yep. Okay. I'm right next to it as well. There we go. That's better. So Minoryx is a small biotech company based out of Spain. We have a product called liraglutide, which is an orally bioavailable, brain-penetrating, selective PPAR gamma agonist. And this is a small molecule. It's an oral suspension, so it's not an injection. It's not a tablet. It's a suspension that can be taken by children and adults. What we see with this product is it's having an action of disease modification. So it's not a cure, but it's acting on the disease to slow the disease down. And the key actions are reducing neuroinflammation, and I think you've heard about the inflammatory process of CALD throughout the day today. We also see a decrease in the demyelination. So that's something that's also important in leukodystrophies. And we also see an action of increasing the working of mitochondria, which are the sort of energy factories of the cells. So really improving that cellular environment. With liraglutide, we actually have very good dialogue with the FDA in the US and also with the EMA in Europe. And with this multi-mode of activity, we have the potential for use of liraglutide in other indications outside of just ALD, which is very interesting and exciting. So I just want to take a little bit of time on this new schematic with some MRI scans and just talk about cerebral brain lesion evolution in CALD and XALD, and really try to sort of simplify with some boxes and also some MRI scans. First of all, you've been hearing about MRI screening and really, in a sense, monitoring for lesions to be identified. So the first box that you see is a box that shows no visible lesions on the MRI and a clean, in a sense, in inverted commas, a clean MRI scan underneath it. Then you have the middle box, the blue box, which says non-enhancing gadolinium negative brain lesions. And this is where lesions are seen on the MRI scan. However, they're not lighting up with the gadolinium infusion. So they are considered as either not growing or growing very slowly. And you can see that bright area in the MRI scan below. And then looking at the far right box, this is progressive CALD. And this is where there is rapid growth of the lesions, which are often gadolinium enhancing. So this is where the lesions take off, there's lots of inflammation, and they're growing very rapidly. In a sense, this is the timing for consideration for, at the moment, bone marrow transplant or gene therapy. And you see the MRI scans underneath there, in a sense, showing increasing white lesions. The arrows that you see at the bottom are, in a sense, the biomarkers. The LES score, lesion volumes, neurofilament light chain, all of these biomarkers increase in their scales as you go through those boxes. Those biomarkers increase before typically there are any clinical symptoms. So you see the arrow a little bit further down to the right, the NFS, the neurological functional scale, and also the MFDs, the major functional disabilities. Those elements start being picked up a little bit later on, typically all the way through the progressive CALD box and time period. If there are no treatments possible and the patients may not be eligible for treatments, this can lead to rapid neurological decline and death, or the vegetative state that we heard being spoken about this morning. So we know there aren't that many treatments available for CALD. Great that we have bone marrow transplant, we have Elicell, but they are limited, and we know that only a certain number of patients have access to them. We also heard only a few patients in the US are being identified early enough as adults with cerebral ALD as well, from the information provided by Dr. Bonkowski earlier today. So there is an urgent need for new treatments, especially when a lesion is identified, because that otherwise you're just waiting for that final box to happen, which isn't the best scenario. We've been hearing about HSCT. It is the standard of care in pediatrics in progressive CALD. It can be if in adults too, if the patients are identified early enough. It's invasive, has its own morbidity and mortality in terms of risks. Often patients are diagnosed too late and are not eligible for transplant. So if there is a way that you can gain a greater window of opportunity to find the right donor, slow the disease down, that would be ideal. Also, as we said, in adults, there's poorer experience, less experience of transplant with CALD, often due to ongoing AMN symptoms as well. So if patients are becoming more immobile, if they have bowel and bladder incontinence, that could potentially make them more at risk of having poor outcomes or infections or morbidity from transplants. Then, of course, you've just heard about Elicell, which is available, fortunately, here in the US, which is great news. So what I'm going to do is take you through some data sets, which are all in the public domain, but also to say that we have actually, with leriglitazone, got a very significant experience in XALD. We've treated over 180 patients through the clinical trial program and also through compassionate use, with more than 120 patients with CALD being treated. So the first piece of data I'll take you through is called the ADVANCE study, which is a study in AMN, one of the largest studies in ALD conducted as an interventional study with 116 men enrolled. It was a 2-year study, a 96-week study with a 3-year open label extension. The primary endpoint for AMN was unfortunately not met, but there are some really interesting and important results for CALD, which I'll take you through. This was published in the Lancet Neurology. The other data I'll take you through is in pediatrics, and this is the NEXUS study, which is still ongoing at the moment. This is an open label study with 23 patients enrolled, running in Europe, and I'll take you through some interim results which occurred at a time point of 24 weeks, which allowed the study to continue, and these were presented at AAN last year in 2023. And then the final data set, which is ongoing and a publication has been presented earlier this year, is on the compassionate use, which is compassionate use both in adults and pediatrics. This is a program we're allowed to run in Europe, and this is really with a large heterogeneous population of CALD patients. We have more than 30 patients now with MRIs, which are at baseline and after baseline. And I'll take you through some data that was published with a specific follow-up in France of 13 patients. So firstly, to the advanced study. And as I've said, the focus here is CALD, not the AMN component of the advanced study. But important to say that when patients were enrolled into the advanced study, they were enrolled ensuring that they were not in the progressive CALD box. So having progressive CALD was an exclusion. Importantly, patients were enrolled both in box 1 and box 2. So patients either without lesions, which was the majority, but also quite a significant number of patients with lesions. So 27%, 31 patients with lesions, which are gadolinium negative, were enrolled into the study. What we saw over the first 2-year period, which is the placebo control part of the study, was that 6 patients on the placebo arm, 6 out of 39, developed the progressive CALD. Whereas no patients out of the 77 patients on leriglitazone developed progressive CALD. These data were driven by clinicians diagnosing the patients, MRI scans being available and being read by independent blinded readers, really confirming both the clinical and radiological diagnosis. The data were also, in a sense, confirmed through the 3-year open label, really sort of showing that ongoing leriglitazone treatment was giving some form of protective effect to stop the development of progressive CALD. And then when we look at some specific secondary endpoints from the study, what we were looking at was MRI scans, looking for the number of patients who were developing lesion progression in the MRI scans. Lesion progression being new lesions being identified, lesions that were gadolinium negative, turning into gadolinium positive, or lesions that were gadolinium negative but increasing in size. What we see is in the 2-year double-blind period is that 3 out of 77 patients in the leriglitazone arm developed some form of lesion progression compared to 8 out of 39 in the placebo arm. Again, that was a clinical and also statistically significant piece of information that we found. This again was reflected in the LESS score. This is the scoring system from the MRIs. And again, there was a significant reduction in the increase in the LESS score with leriglitazone treatment. You can see the middle figure showing a very small amount of increase in the LESS score after 2 years with leriglitazone compared to the placebo population on the right hand side in the grey box. And then the final figure is the neurofilament light chain data. And I think it was being explained earlier that neurofilament light chain is increased in AMN patients, so they have more ongoing axonal degeneration anyway. But what we see with leriglitazone treatment is that that level was maintained, whereas in the placebo arm, the neurofilament light chain values were increasing over that 2-year period. Again, significant result. And again, all of these results were reflected again and confirmed in the 3-year open label. And then moving on to the Nexus study, this is the pediatric study with 23 boys. This is ongoing. In a sense, no new patients will be enrolled, and we actually will be having the last patient visit for the confirmatory analysis actually next week. So we should have some results to share with you next year. So as in final results of the analysis. So here you see that we were enrolling boys who were either having non-enhancing brain lesions identified de novo, or having lesions that were enhancing gadolinium positive in the final box as well. With pediatric CALD, there is some very good natural history data, and it is understood and written in several publications that the expected self-arrest rate is 10%, not progressing at 2 years. So, and also the neurological decline in these patients would also stop worsening if they had self-arrest. So the study was built on understanding that this 10% rate is the natural history. So we needed to show liraglutide to be better. What we have at the interim analysis is that we had 11 evaluable patients at 24 weeks, and all of them were meeting what we would call the continuation criteria. And that was either termed as being arrested clinically or with having stable disease without significant growth. All of these data will be reconfirmed with the full 23 patients later on in terms of the primary endpoint analysis. A few descriptive pictures just to really show on a clinical basis what we're starting to see from that very early data. The first figure you see on the left is the natural history from Jerry Raymond. That was published about 5 years ago. And here you see that the neurological functional score from the time point of diagnosis and gadolinium enhancing lesions being detected starts to increase fairly exponentially and rapidly without any treatment. What you see in the center figure is the liraglutide patients at that time point of the interim analysis. And here we have 15 patients. It's surprising, but there are 15 patients in that very low line. Early data, but reassuring at that time point to say that there's no worsening, in a sense, with the product, and the patients are neurologically stable. And then the figure on the right is the outcomes of what would be expected with HSCT. And again, it's what we see there is that the neurological functional score remains stable after treatment, typically in the majority of patients. And we're reassured very early that that seems to be the case with the liraglutide at the moment as well. But we will see with the final analysis. And then when we look at the MRI data and the LESS score specifically, we see on the left the liraglutide data from the Nexus study. This is all 15 patients again over the first 24 weeks, where we have all of the patients, or 15 patients, but some patients were in the study for longer. And what we see there is, in a sense, a stabilization of that LESS score increasing, and reassuring again that this is something that we can monitor. At that time point, we were happy to continue the study, and that was the key reason for the analysis, but also giving us a sense something was happening. In the center figure, you see the LSL data, and on the far right, you see the transplant data effects on the LESS score. And again, you see that the LESS score does increase a little bit, but then stabilizes, and that's typical. And for us, we're not doing a head-to-head comparison, but we feel reassured when we just visually look at these figures. And then the compassionate use, as I've said, we've got many patients on compassionate use in Europe, both pediatric and adult. But what I want to share with you just now is some adult data, patients aged between 19 and 67 years of age. And these patients were enrolled into a study by a French team in Paris, and they were followed up for over a year with regular clinical evaluation, MRI evaluation, and they followed more than they followed 13 patients for over a year. What they saw was that 10 out of the 13 patients were clinically and radiologically stable, and out of the 10, 4 actually improved clinically with some improvement in proprioception, some improvements in cognition. 2 patients did decline, unfortunately. 1 patient died of COVID-19. But another important fact that they saw was some patients who had gadolinium enhancing lesions of the internal capsule, which is typically a sign of very poor prognosis, actually had that gadolinium enhancement reversed. So they became non-enhancing at that area. So that was really positive news for that was seen. And then 5 patients actually came into the study on the transplant list, and 5 out of 5 were actually taken off the transplant list because they had become stable. So this is written up, and this is the reference for the publication. And then in terms of safety, we've been hearing a lot about safety and toxic effects. We do, of course, see adverse event side effects from any product that we give. The reassurance is that the product actually comes from a family of drugs which have been used widely in diabetes, and the product is expected to have problems of edema, which is fluid retention and puffiness, typically in the ankles or looser tissues around the face. And that has been seen, but typically that's been mild to moderate, not been associated with any sort of heart failure, but we do monitor with echocardiograms through the course of the studies. And it is reversible if the product is withdrawn. And that's typically seen more frequently in the adults. In the pediatric patients, it's less frequent. Maybe it's because the children, the boys, are more active. We haven't, and typically it's just very much facial or periorbital around the eyes, bit of puffiness. There have been, again, in pediatrics, no cardiovascular events, and the patients continue to grow and follow their growth curves, and no withdrawals due to adverse events. So that's the clinical program that's been ongoing. What I want to take you through just now is the Calyx study, which is a study that is been set up, discussed with the FDA, a phase 3 study. So a larger study, but in rare diseases, large is still 40 patients. So we're doing a study called Calyx in adult CALD. It's a randomized placebo-controlled study. We're looking for patients who are adults, so greater than 18 years of age, with a formal diagnosis of cerebral ALD, with gadolinium enhancing lesions, with a less score of greater than 0.5 and less than or equal to 12. Patients who are not recommended for bone marrow transplant or not willing to undergo transplant. And we're looking for 40 patients in a study that will be a 1-to-1 randomization with placebo. The reason we're having to look at placebo here is there isn't any natural history that's been published or written up for adult CALD to really sort of compare very strongly with. So we have to do a placebo-controlled study. We have sites open already here in the US and South America, and we're opening new sites in the UK, Germany, France, and Spain later this year. So it's becoming very much a global study. The study is called an adaptive duration study, and I'll explain that in a second. So we actually have an opportunity to look at the efficacy, the outcomes, at an earlier stage rather than waiting until the end of the study. The primary endpoint for the study is time to death, comparing active to placebo. And again, this is because there is no natural history written up carefully for this patient population. Key secondary endpoint is the less score. This is the study design, and you can see that patients will come in, be screened, have their consenting procedure, which you've been hearing about earlier, and then be randomized 1-to-1 in a blinded fashion. So the doctor, the patient, ourselves as Minoryx, we don't know if the patient is on active or placebo. They'll be randomized 1-to-1, either placebo or liraglutide. When the last patient enrolled, patient number 40, reaches 18 months of treatment, we're allowed to perform an analysis looking for time to death of the primary endpoint. And this will be reviewed by an unblinded data monitoring committee. If there is efficacy, then all patients will transition to open label treatment, which is the top line that you see. If not successful at that time point, the study would continue double blind placebo control for another 9 months. That analysis is repeated again. If successful, all patients transition from placebo to active. If not, then the study continues to 36 months, which is the end of the study. Here are the sites. So the sites in the US are in Baltimore at KKI, in Boston at MGH, Stanford, in Minnesota, and then we have sites in Brazil and Argentina. And then in Europe, we will have sites in the UK, in London, site in Germany in Leipzig, in France with Fanny Michel in Paris, and then also in Spain with Dr. Morales in Madrid. So I'll stop there, but also to say, first of all, through the whole program and the way that the ALD community pulled together to help support enrollment, engagement, the work that you're all doing to get, especially right now, adult men back into having MRI scans is fantastic, and we hope we're supporting that with some of the activities to support the Calyx study. But we do need as much help as possible to try and enroll into this very difficult study, which really will give us a very clear answer very, very soon if we get the study enrolled fully quickly enough, which we hope to do with new sites coming on board. So thank you very much for listening and all of the support that you give.
Thank you. Thank you. We're very grateful for all the work Minoryx is doing and all the support. Any question? Yeah, I have a question over here.
Thank you. Oh, gosh. Okay. I am in line to participate in the Calyx phase 3 study. Should I go get my MRI and show cerebral involvement? Assuming I fail that and get disqualified for, the study, what are the chances in the future that Men 102 will be available for people without the cerebral involvement?
Sure, thank you very much for that question. So what we want to first of all do is have the study completed so that the FDA can review the data. That's first of all the first step we have to do. We have, of course, got some of the information from the advanced study that shows there is a protective effect even in patients without lesions. However, the data that will be presented to the FDA will be the Calyx study, and this is a study with lesions. So we have to do it step by step, and that's we can't jump.
Any other questions? Otherwise, can I ask, just based on what you're hearing from the sites, how long do you think it'll take to enroll Calyx?
So with the additional sites coming on in Europe, where the patient populations are probably a little bit more concentrated, there's the public healthcare system where patients are engaged in ongoing MRI monitoring. We're hoping by the middle of next year we should have all 40 patients in.
If no other questions, thank you so much for the work you're doing.